Hello, I'm Dr. Jeffrey Goldberg, President of the American Academy of Orofacial Pain. Our organization represents those dentists who specialize in the treatment of facial pain. We support the research, awareness, education, and advancement of orofacial pain in dentistry and the medical fields. We are very pleased to be working with the Facial Pain Association, particularly in the area of neuropathic facial pain. We understand through our patients the great frustrations and challenges of living with this kind of pain, and we support your efforts to bring people together, seek treatment, help, and support for those who are affected by and living with these conditions. Thank you for the opportunity to work with you, and we look forward to working together more in the future. Thank you.
Good evening, and welcome to the Patient Q&A, the Future of Facial Pain Research. I'm happy to welcome Dr. Ray Sakula, Professor of Neurological Surgery at Columbia University and Chair of the FPA Medical Advisory Board. Joining Dr. Sakula is Amin Tahiri, VP of Clinical Development at Noema Pharma. I'm Brandy Underwood, Manager of Marketing and Communications for the FPA, and I'm joined by our CEO, Melissa Bombick. Before we get started, I'll ask that attendees submit questions using the Q&A feature on your screen. Dr. Sakula is going to share a few slides, and then we'll get to as many of your questions as we can over the next hour or so. Dr. Sakula, Amin, take it away.
Okay, good evening. Thank you, Brandy. Thank you, Melissa. And Amin, thank you for joining us at 1 a.m. your time to help our patients. So for now, Brandy, I'm going to ask you to stop sharing that presentation. And I'm just going to talk for a few minutes. So good evening. You know, the purpose of this talk is to share with the attendees, you know, what is new in facial pain research. And so first and foremost, we're going to talk a little bit about basimgurant, which is a drug from Noema Pharma, and we have the Vice President from Noema Pharma, Amin Tahiri, here. It's 1 a.m. his time, as I mentioned, and so we're delighted that he could be with us. That's probably the most exciting development in at least the medical treatment of facial pain. I'd like to make it clear that I am not a paid consultant to Noema Pharma. I receive no monies from Noema Pharma. But I am a site investigator, and so let me just share a few items with you. Yeah, darn it. So, Brandy, if you go ahead and just put up the presentation, you can start at the first slide, and then we'll move on to the next slide. So as I mentioned, I don't have any disclosures. Next slide, please. And then we can just move along, if you would, to some of the sites where this study is occurring in the U.S. and elsewhere. You can just move through. All right. So these are the 4 sites, and so if what we talk about tonight is of interest to you, excuse me, these are the 5 sites in the United States. If what we talk about tonight is of interest to you, or if you have questions, for those of you who are joining us from sites outside of the United States, I know some of the international sites, but certainly Amin can share those with you. You know, I think certainly basimgurant, which we're going to spend some time talking about, is an exciting development. It's really the second drug that has been proposed for trigeminal neuralgia, specifically proposed for trigeminal neuralgia since the 1960s. The first drug unfortunately did not make it into the U.S. And at this point, there really are no plans to proceed with that drug. And so for some period of time, we were quite dejected that that had occurred. And then along came Noema Pharma. And I can tell you that the company is really very earnest about helping patients with trigeminal neuralgia. I've had nothing but great interactions with them. So at this point, I think I'm going to turn it over to Amin Tahiri just to say a few words from Noema Pharma and start the conversation. Good morning, Amin.
Good morning and good evening to everyone. Thank you first to the facial pain community and to the patient that they shared with us so many information. At Noema Pharma, probably the first thing we did when we considered developing this drug in trigeminal neuralgia is to try to understand the disease from you. What is the experience you have with the disease? What is your expectations? What are the therapeutic options you have? And what is important for you? Thanks to your insights, we have been able to develop a study protocol. And I remember we had a very insightful session with 2 or 3 members from the Facial Pain Association where we reviewed several potential designs. And we came out with the study design we have today, which is probably the one which is the most acceptable to the patients. So I'm really excited to be here. This is the second attendance of Noema to this FPA annual conference, and I'm very happy to share with you more details. The company is based in Basel in Switzerland. The company is a startup. We are 23 today, and we are developing specifically this drug in trigeminal neuralgia plus other compounds in other indications such as stuttering, Tourette syndrome, or atypical depression.
Well, thank you. Okay, Brandy, if you'd go back to our slides, I think I'm just going to ask you to move forward to the design of the study. So, okay, so basically with this drug, if you meet the requirements, which we can get into in a moment, then you cannot stay on carbamazepine or oxcarbamazepine, so you do have to taper off that. So for some patients, what I've found, and so far our site, we've been up and running for I think about 6 weeks, and we've enrolled 4 patients. Because it would really make it difficult to understand the effects of basimgurant if you had carbamazepine or oxcarbamazepine on board. You have to be able to taper off of that drug. So that's a one consideration that you have to make. If you know that you can't taper off those medications, then this study is probably not for you. But if you think you can for a short period of time, then you go through a variety of screening assessments, and then you enter a period of 2 months where you're given the drug, and you're titrated upwards on the drug. At this point, having enrolled 4 patients myself, and I also flew to London to spend some time with Dr. Zakrzeska, who had already, because they were started ahead of us, had already enrolled 6 patients. She gave me some advice on how to titrate patients based on their experience. And the experience that they'd had was that some of their patients had some difficulties with sleep. Now, that was really the only untoward side effect of the medication, which is pretty good for putting a new medication into your system. And so that caused us to slow down the titration a bit and was very helpful. So to date, we have 4 patients on the study, and 3 are doing quite well. And the 4th is really just getting started on the drug. So we're at the conclusion of that 2 months where you will definitely receive the drug, then for the next 3 months, at some point you will definitely be randomized, meaning at some point the drug will be taken from you and you'll be given a placebo. You won't know and we won't know when you're given that placebo, but that's the only way that we could determine whether you're actually responding to the drug or not. And then what I think is really unique and great about Noema, and as Amin mentioned, it's a small company, just in the 20s, and I'm not an expert in this, but I think most of us know that trying to bring a drug to market is quite expensive, and so I've been really impressed with their earnestness. I actually moved my practice from the University of Pittsburgh to Columbia University. And, I think they knew how much I wanted to be a part of this for the patient's sake and, hung in there with me. So I just find them to be very good people. But in any event, if you like the drug, at the conclusion of that randomized portion where you're either getting the drug or placebo, the company will give you the drug for a full year at no cost. And then following that, our hope is that the drug will be approved and that it works at least for some subset of patients with one or more types of facial pain. So I think at this point, I'm going to ask Brandy if there's any questions that have come through, and for either Amin or me, or for both of us, or Melissa, sorry.
Yep, I'm going to ask you several questions. We have a ton of questions. So I'm going to go ahead and start with some that are relevant to the study specifically. And then there's a bunch of questions about things that don't necessarily have to do with this study, but have to do with research in general.
Okay.
So somebody asked, and I'm not sure if you said this already, how many visits to the study sites are required?
Well, I think it's 5, isn't it, Amin?
Yeah, absolutely. We, in this protocol, we have 5 study visits in person, and many other visits which are remote, which are safety follow-up with the investigator. But in person, only 5 visits. Yeah,
and I mean, correct me if I'm wrong. Doesn't the company reimburse for travel expenses and things?
Absolutely. So you have seen that we opened a network of 5 centers, 5 experts of the disease across the US. And we are very happy to support the travel cost for patients who are willing to travel from another state or from the same state to the center. And for that, Ray and all investigators, they have access to travel concierge who will be helping you to organize a trip, to book the train or the flight tickets, the hotel if needed, accommodation, everything, without that you have to advance the fees. Absolutely.
And I'm going to come back to that in just a second, but I want to say this one more time for anyone that's maybe joining a little bit late. There's nothing wrong, I think, with a physician being a consultant to a company. Companies often need that, but I am not a consultant to this company. I don't receive any monies from the company. So I'm just, a site investigator trying to get this to the right patients to see if it's helpful. So I don't know anything about the stock of this company, not a shareholder, anything of that nature. What I would say, is that I feel like with my clinical coordinator and nurse practitioner, we're calling patients every few days just to check on them, seeing how they're doing. And it's just been going very well.
That's great. Go ahead.
Melissa, I'm just wondering if I forgot any part of your question. Pardon me.
Nope, that was that answered that question. I have one more on the study itself, and then I think I'll move on to some of these other more broad research-based questions. But a couple of people are asking about timeline. So they want to know, somebody got through the first screening and is wondering when the next level screeners would, the second level screeners would reach out. Another person asked about timeline of the drug altogether. Like, what are we looking at as far as availability?
Do you mean availability till the drug is available in the marketplace?
I think, yeah, basically they just asked if timeline for the availability of the drug, but that would be my guess.
Amin, do you want to handle that?
Absolutely. So we are today running this study to understand the effect of the drug, and we have already interactions with the health authorities, specifically the FDA, the US FDA, to basically to understand which information they need from clinical perspective, but also from manufacturing, non-clinical, what we call clinical pharmacology, which are mostly to understand the safety and how to use this product. And basically, we need to provide all this information to the FDA. The FDA needs to know how efficacious is the product, how safe it is, what are the best conditions to use this product in the patients, and if the risks are lower than the expected benefit. This takes some time because we need to complete the study, and we probably need to generate potentially additional data, and then the drug will be approved. Today, probably we expect to finish the study around the end of 2024, based on our projection. Plus, we will need at least a year or maybe a year and a half to generate the additional data and to interact with the FDA and to file the market authorization. So we are speaking about at least 2 to 3 years before having best case the product on the market.
Thank you.
So I would just tell the attendees that that Noema Pharma does have a sponsor booth here within the conference platform, and we may be able to get back to a couple questions on this particular study, but that's another great place to go to ask questions. Their staff is there available to answer questions. So, but there's some general questions on research. Like there's one that asks if there's any research being done for people who have both bilateral and occipital neuralgia. So the atypical, what's commonly called that, and then occipital neuralgia. Are you aware of research studies being done for that?
Sure. I mean, tomorrow morning, our first presentation from Dr. Politzis is a patient, and we decided, Melissa and her team, as with me, decided to include this video because it's, this question is great because it's so common in patients with facial pain, as so many have occipital neuralgia. So in this video, you'll see Dr. Politzis interviewing a patient that had surgery with her more than 10 years ago for occipital neuralgia or migraines, because it depends on how the terminology that you use. But there's certainly a lot of different techniques that are available for patients with migraines, occipital neuralgia. In terms of actual preclinical research, meaning research that's not yet in patients, there's quite a bit happening. I mean, Amin can speak to the fact that that all of the big pharma companies are working on medications for patients with migraines and occipital neuralgia and things of that nature. My own lab is working on a drug target for people with these types of things. And, there's so much. What I think is really exciting about trigeminal neuralgia, occipital neuralgia, is that there's so much happening. Well, so just for those of you who are not, in the clinical arena, we divide these things as preclinical and clinical, meaning if it's clinical, it's already in patients happening. If it's preclinical, it's usually meaning it's in an animal model. But there's so much exciting work being done right now. For example, there's a new animal model that's funded through the National Institutes of Health for trigeminal neuralgia. So it's too early to really say whether this model is going to be a good representative of trigeminal neuralgia, but that's exciting because there hasn't been a model of trigeminal neuralgia, a new model, for maybe 35 years. And so that's super exciting. There's at least one or two other groups working on new models for trigeminal neuralgia. So for those of you that might not understand, what you want to do in preclinical science is you want to try to replicate the problem in an animal, usually a smaller animal, for cost reasons. And so in this case, we're talking about rats. And so, there's often a disconnect between the animal model and how the disease in humans, and the goal is to make the model as close to the human disease. And so I can tell you that the new model that's being proposed, that's currently funded through the National Institutes of Health, is I think certainly much closer to what the kind of trigeminal neuralgia that occurs in at least some types of patients. The old model is a very good model for other types of trigeminal neuralgia. So it doesn't exclude the prior model. And then you might say, well, okay, that sounds okay. That doesn't sound so exciting to me. Well, it is pretty exciting because there was a time when the National Institutes of Health really wasn't putting any money into trigeminal neuralgia. And so that's pretty exciting. And so, my group has a 5-year study through the National Institutes of Health. We'll be putting in our next really large proposal in October. We don't know if we'll get it, but that means there's 4 groups of us in the U.S. working on this proposal. So that means there's, researchers interested in this problem. There's a number of other groups in the U.S. and internationally interested. I think some of the work that's being done, let's say in Denmark, is super exciting. There's really exciting work in Italy. Melissa and her team have been working a lot on a patient registry. So what does that mean? Well, I'll give you an example from my clinic today. So the patient registry, there's been lots of work. There's a variety of international experts, again, from Italy, from the UK, obviously from the US, a number of us trying to determine what's the intake we need for patients. What kind of questions do we need to ask? What kind of pain do you have? What's the severity of the pain? Where is the pain located? Did it change character? So here's an example. So I saw a patient today, 72 years old. She developed what I think anyone would term classical trigeminal neuralgia 9 years ago. For the first 6 years, her pain was perfectly controlled by oxcarbamazepine. We get an MRI. She shows fairly significant deformity of the nerve by an artery. But she has what she describes like a creepy, crawly feeling on the top of her head. That, medically speaking, that's called formication. And then she has like a burning feeling along her nostril. So, why is that important? Well, some surgeons might say, well, we'll just do a microvascular decompression, that'll fix it. Well, that may fix her, but it would be so wonderful to have a registry where we could say, okay, Melissa, I need to find all the patients who've had trigeminal neuralgia for 9 years that have formication on the top of their head. How did they do with microvascular decompression? I mean, that's an example of what the power of what this registry will do. And I think, the registry most likely will be available for patients with your help, because it requires patients to input the data. And part of the process that's slowing things right now is that the Facial Pain Association is acutely aware of privacy issues and things of that nature. So they're not rushing the process. They want to make sure they have the correct platform, be able to access the data correctly, make sure there's not going to be any breaches, all of those types of considerations. But I don't know. I mean, I could go on and on, but there's just a lot happening now that just wasn't happening 10 or 15 years ago. And the fact that a company, again, like Noema, I'm not an expert in this, but bringing a drug to try, even just to trial or then to market, is so expensive. And so when you have a group of passionate, dedicated people that are willing to do that around trigeminal neuralgia by the National Institutes of Health is not an ultra rare disease, but it is a rare disease. And, it's not diabetes. So, there's not the same, there's not the same financial upside for companies out there as there is for diabetes or high blood pressure or whatever. So, we're kind of lucky that we have a company that's interested in helping TN patients.
It's so exciting, and we are really, really excited about this and all the research that's going on. As you mentioned, we're involved with this patient registry, and we're working with researchers around the world. So it's really very exciting. What about calcium blockers? There was somebody.
And before you leave that topic, Melissa, maybe you could just mention. I mean, don't you think it's kind of inspiring how none of these researchers are being paid to do this work on the registry? I mean, how many hours have gone into this?
Exactly. I mean, we have spent, just going round and round to kind of develop the surveys and the parts and pieces that go into it, so that they find out the right information, so that they are done in a way that people understand and answer the questions as to get the information that we're trying to find out. And there are experts in not only, medical research, but in survey design who are working on this, and they're not being paid. They're volunteers, and we really have a strong team behind it. So it's very exciting, very, very exciting. We did have someone who asked about calcium blockers and said they were having some success with that. Is that something where there might be some research, or is that, something that people are aware of?
Well, I mean, gabapentin is a calcium channel blocker, and I just say how it is in terms of my experience. I mean, gabapentin is a great drug for certain types of neurological problems. It's not a particularly good drug for many patients with classical trigeminal neuralgia, but let's say you're in a car accident and your face hits against the windshield and you have an injury to the peripheral part of this, to the trigeminal system. That's what might be called a traumatic trigeminal neuropathic type of pain, or neuropathy. That's something where calcium channel blockers can be and are very helpful, extremely helpful. And yes, there's a fair amount of preclinical work being done on that. I must plead ignorance. I don't know if there are any, calcium channel blockers in the pipeline. I mean, are you all? I don't imagine. Are you working on anything in the calcium channel family?
No. And I think in the pipeline of the drug which are being developed, there is nothing specifically addressing the calcium channel, if I remember well.
Yeah.
There is a drug, there is a compound which is at early preclinical stages. As you explained, preclinical is way before the drug is basically tested with patients. So it's in animal or even sometimes in cellular models. And I think one is exploring this option, but it's really early. So it means that this compound, because we cannot call it a drug at this stage or even drug candidate, this compound can go to the clinic in probably, if everything is positive, in several years.
Yeah. And I think
only one.
Yeah, just to follow up on that, a lot of the preclinical work has really been focused on sodium channel blockers. Yeah. And there was a lot of momentum to suggest that was the way to go. And that's where there was some pretty nice work on these glutamate channels, which is where basimgurant comes in. But it's been and GABA channels, but that's where Noema has had some real insight into considering this drug for facial pain. And I don't know if you want to say anything, I mean, but that if you were to say, like, it's kind of like in life where, I don't know, everybody's driving this kind of car, and then all of a sudden people just, somebody comes up with this thing and it's like, wow, we should be doing electric. Like Noema's come up with this glutamate drug, and all of a sudden it's looking like we should have been looking at glutamate a lot earlier.
This is very interesting what you say here, and this is exactly what we observed once we started sharing with patient community and with other healthcare professionals that we are developing this drug in this indication. Many people and many scientists told us this makes complete sense because without being too complex, glutamate is in receptors in the brain. They are used basically what we call signal transduction. They are like amplifier, sound amplifier. You get a signal in this, if those glutamate receptors are overactive, the sound which is exiting through the speakers is much higher. And our understanding is this exactly what is happening with trigeminal neuralgia. Because the glutamate system is overactivated, those receptors are overexpressed. There are too many receptors and they are too responsive to glutamate. A normal signal, which is touching the face, which is the sense of cold, which is eating or brushing the teeth, which is drinking, triggers a reaction which is not normal, which is pain, while it should be simply an information that you have cold, you have pressure on your face. And this is our hope that by modulating this glutamate system, which is becoming a little bit out of control, we will reduce this signal amplification to the level that it will not be any more pain. So this is the rationale today for glutamate system. And it looks like it's very promising pathway to support patients with trigeminal neuralgia. And let's hope that the research will be positive on that.
Sure.
What about, I know that earlier, Dr. Sakula, you mentioned neuromodulation and Dr. Plitzis in the video that we'll see tomorrow. But what about deep brain stimulation? There were a couple questions about that, wondering if there's additional research into the effectiveness of treating TM using that method.
Yeah. So there has been some studies, and in fairness, the emphasis within the academic neurosurgical and neurological communities has changed a little bit to focused ultrasound. Unfortunately, the first trial, and we just had a presentation, is the first trial using focused ultrasound for trigeminal neuropathic pain was negative, and so that is really disappointing. And the lead investigator on that is a terrific person, and again, just working really hard to try to find another therapy. But right now, focused ultrasound is not looking, at least at the target that they had, is not looking like it's going to be particularly effective for patients with this problem. In terms of DBS, I mean, there's not a whole lot out there. There's a few reasons. I mean, right now I work in the U.S. with the most experienced deep brain stimulator surgeon in the United States. He's done more than 1,800 procedures and one of the really early pioneers. He came from Montreal, where this was really pioneered. It's tough to get them interested. It's not that they don't care, but it's not approved. So there's no way to get patients approved for it. It's exorbitantly expensive to pay out of pocket for it, and there's not really good evidence to suggest that it would be helpful. I've wanted to send some patients for it. I guess you could say that superficial brain stimulation has been done in the past, what is referred to as motor cortex stimulation. I don't think we're going to hear much about that tomorrow. I frankly have not had much luck with motor cortex stimulation. I'd say 13, 14 years ago, we sent maybe 10 patients for it. Didn't really see any really positive results. Certainly, if you want to talk to an MAB member about it, I know that Dr. Jeffrey Brown at least did a lot of motor cortex stimulation over the years. I'm not sure if he's still doing it these days. You'll hear a talk from Dr. Politzis, as I mentioned, and you'll also hear a talk from Dr. Chris Winfrey tomorrow about let's just call it superficial stimulation for facial pain. That's been very effective in many patients. But deep brain stimulation, I think it's an area of to be explored further, but there's not a lot that I can add to that right now.
Excellent. Thank you for that. Can you explain or give us some, you touched on it a little bit, why it's so important for people with facial pain to participate in clinical trials?
Oh, well, I mean, I guess what I would say is that in our clinic, and if you get interested in participating in this NOEMA trial, there's no competition at all. As I said, there's 5 sites, and we can hook you up with whichever one makes the most sense geographically, or if you've got family in one city or something like that. But I mean, without patients being enrolled, this drug can't possibly get to market. I mean, I guess that's fundamentally where we are. But at the same time, we are in no way twisting patients' arms to be enrolled in NOEMA. Well, first of all, we don't need to. The safety studies have been done. The drug's looking very clean. Speaking personally, I've had 4 patients not having any significant problems. Some early sleep disturbance, but nothing, I wouldn't say anything even as harsh as what you experience on carbamazepine or oxcarbamazepine early. My colleague, Dr. Zakrashevska in the UK has had a good run with it so far. So, why is it important? Well, I mean, we can't get any of these drugs to trial without participation, but I don't know. I'm not sure who asked the question. That's not important. But what I've found over the years is that there is something unique about trigeminal neuralgia patients. They tend to really get involved in research, whether it's just a retrospective clinical research project when we're calling them, asking them questions to see how they did with this or that procedure. They tend to really want to help the next group of people stricken with this problem. Just like, a good bit of, I think, the FPA office that works with Melissa and the board of directors are all either current or former, sufferers of trigeminal neuralgia. So they're all doing their best to help the next group of patients with this problem and make it a much better situation for them.
If I may, Ray, I would like to add something.
Please.
Why it's important for patients to participate to studies and to be absolutely fair to address and respond to the study questionnaires and assessment and to be extremely compliant. It's in fact when we develop a drug and when as a clinician we want to use a drug for patients, the first question we ask ourselves, does this drug work in this indication? Does this drug work better in a subtype in a specific patient versus others? For example, Ray explained that patients with a certain type of pain induced by trauma, for example, will be likely more to respond to have therapeutic benefit from pregabalin or gabapentin than others. So these are the kind of question the first question we want to address. Does this drug work for this condition? The second question is, how safe is my drug for the general population? And how safe is my drug for people who have problems with liver, people who have problems with their renal function, with their kidneys, people who have hypertension, women who are in age who want to get children? How my drug is safe in all this population? How can I use it best? And to be able to understand if the drug works, if the drug is safe, and what are the precautions we need to have to be able to give this drug to the patient. We need to give this drug to several patients with the indication. in order to, we do a certain time statistics to compare if this drug works. Yes, no, compared to placebo. And then this will enable us first as a researcher to be confident and to be able to go to the health authorities and say, okay, this is the drug we developed. This is what we observed in clinical trials. And now we would like to go ahead and have this drug approved. This is the critical reason why we need your participation. The second reason, and Ray explained it earlier, there are what we call non-clinical models to try the compounds before using them in clinical research and in clinical practice. Those non-clinical models are imperfect. You cannot model perfectly how the drug will work in human based on animal model. There are models which are, some are quite old, some are being refined, like the model Ray is working on, basically to try to replicate trigeminal neuralgia in animals by what we call, you take a nerve and you try to create something which is very similar to trigeminal neuralgia. The results you see in animal models, how they are not automatically applicable for human. And we always need to have very clear signal before starting the drug, using the drug in human, but to be able to confirm the efficacy and to know how to use it, we don't have any other choice than to have your support, your participation, your compliance in the study to understand if the drug works or not and the best way to use it and prescribe it. I would like to clarify also something to be extremely precise. In the study we are conducting with basimgurant in trigeminal neuralgia, as Ray explained, we have the first part of the study where everybody gets the drug. The second part of the study is the period where you may be randomized active or placebo. And at the end of this randomized period, you, if you want to continue in the study, you will have access to 1 year of what we call open label extension. It's a year where the drug is, you are in the study, you have the drug, and you are followed by your investigator for 1 year.
That's very helpful. Before we move on to another question from Melissa, I mean, anything else that comes to mind to you that you'd like to clarify? I mean, we'll certainly swing back to, but anything you'd like to show? I'm probably going to show some of those slides tomorrow, but is there anything on the slides tonight you'd like to show, or?
I think it's we explained how the study procedures are organized. We gave some information about the compound and where we are with the compound in the global development. You gave a hint, and it's on basically your first observations, and let's hope that this observation will be confirmed across the study and across the other centers. And yeah, so if there are no, thank you, but happy to address additional questions from the audience.
One question was about what results do you expect? Where do you expect this to go?
Well, I'll answer that first, and then ask Amin to answer that. I mean, I think he touched on some of that in terms of, you know, there are different types of trigeminal neuralgia, even within the so-called classical trigeminal neuralgia family. So right now, this trial is for patients with mostly paroxysmal or intermittent pain, but they can have a continuous pain to be in the study. And so you know, we first want to find out, does it really work for that group of patients with that type of pain? Because that type of pain is different than the patient with a traumatic injury to the nerve, let's say from a dental injury or a blunt trauma injury, or it's somewhat different than a patient with trigeminal neuralgia due to MS and multiple sclerosis, or people with post-herpetic zoster. So, you know, right now, and this gets a little in the weeds, but there's no way NOEMA can go after every indication of trigeminal neuralgia, cannot go after patients with multiple sclerosis, herpetic zoster. But if it's so we want to first know that. And like Amin said, we want to know, is it great in people under a certain age group, but doesn't seem to be as effective in an older age? I mean, I don't know any of that. That's not what I'm saying. But, who does it work for? Over time, we're going to want to know, though, you can bet that if this drug is approved, physicians are going to be using it off label in a very responsible way and this means not going to be able to talk about this, but we're definitely going to be trying it in people with multiple sclerosis, pain, post-herpetic neuralgia, all these other types of trigeminal neuralgia. Amin, do you want to add anything?
Different perspective, but exactly the same somehow information. So what we have understood when we started working on in this indication is basically trigeminal neuralgia. There are different types. The first type is what is called classical trigeminal neuralgia, where you have the trigeminal nerve compressed by the vessel. The second type of trigeminal neuralgia, when there is an underlying disease, what I explained, herpetic infection or multiple sclerosis, or, for example, a tumor present on the nerve. And this is what is called secondary trigeminal neuralgia. And the third subgroup is what is called idiopathic trigeminal neuralgia, because we don't see any reason why the patient is having those pain attacks. So and the study today is focused on classical and idiopathic, because those are the types of trigeminal neuralgia where we believe that the mechanism of action is likely to provide pain relief to the patients. So the first question is, does the drug work in those type of trigeminal neuralgia? The second question we want to address is, that in trigeminal neuralgia, all patients will have what is called paroxysm or pain attacks or flare-ups, those intense shock of pain. And those paroxysms you could characterize with frequency, how often you have a paroxysm per day, and also severity, how severe are paroxysms. In subsets of patients, in some patients, we have also, in addition to the paroxysm, a continuous pain. They are in pain for a certain time during the day, and this pain is usually less intense than the paroxysm, but still present. There is unclear understanding in the scientific community if there's two types of pain which could be present in some patients are triggered by the same physiopathology. And if a drug works, will it have more impact on the paroxysm frequency, paroxysm severity, or it will have impact also and hopefully pain relief for the continuous pain? This is the second question we want to understand. If the drug works, what is mostly the pain which is reduced? Is it continuous pain or paroxysm? The third question, and this is extremely important, is how the drugs helps you as a patient to go back to as normal life as possible. And I give you one example. And very recently I had to go to the hospital for some issues, and I had pain, but it was fine for me to have a lower pain if it was permanent, because I could work. While for some people, they prefer to have one episode of pain in the morning and they are done. And this is very personal decision, because every person has its own constraints, daily life, and characteristic of pain. And what we want to understand is, regardless how the pain is impacting your life, we want to understand how the use of this drug help you to reduce the impact of pain on your daily functioning. Because this is important. We know that trigeminal neuralgia is triggered pain. And we had the example of one patient in the study who, from the numbers of paroxysms, showed almost exactly the same number of paroxysms. But from the interference of the pain, he said, I can do almost all what I want. And therefore, he considered that he has anymore no interference. And this is considered by the patient as meaningful improvement. So basically, first question, does it work? Yes or no? Second question, does it work? Yes or no? On the paroxysm or continuous pain? And third, does it bring improvements in the daily activities of the patients? These are the three questions we want to address from efficacy perspective, and always we want to understand safety and how best to use this drug in patients.
Excellent. Thank you, Dr. Sakula and Amin. I have another question from the audience here. What conditions exclude patients from the NOEMA study?
Well, as Amin said, you have to have what's called classical trigeminal neuralgia or idiopathic trigeminal neuralgia. Now, those are defined currently by a consensus board of the International Headache Society and the International Association for the Study of Pain and the European Academy of Neurology. So classical trigeminal neuralgia is that mostly paroxysmal sharp-shooting intermittent pain. And in this case, those patients have an actual deformation of their trigeminal nerve by a blood vessel. It's not that this is a perfect classification, but we have to go with what the consensus is at the point. Idiopathic trigeminal neuralgia is the same clinical characteristics, but they don't have a deformation of their nerve. So they can have an artery just contacting the nerve or a vein just contacting the nerve, and they're considered to be idiopathic. Maybe to make it more straightforward for patients, if you have trigeminal neuralgia due to multiple sclerosis, you are not a candidate for this study. That doesn't mean this drug won't be good for you in the future if it makes its way into the market. If you have post-herpetic trigeminal neuralgia, you are not a candidate. If you have a post-traumatic type of trigeminal neuralgia, you are not a candidate for the study. Those kinds of exclusion. Did that answer it?
Yes. Please go ahead, Amin.
Amin, do you want to say something?
Yeah, in addition to that, so you're absolutely right. These are the type of diseases which could not be included in the study. In addition to that, there are a few conditions, and this needs to be explained with you in pre-screening visit and screening visit, which basically can put you at risk if you are part of the study, because we are still in a drug which is not fully developed. We don't know everything about the drug, and we are learning. One of these conditions, for example, if you have severe hepatic impairment, if you have severe renal impairment, you cannot be included in the study. For the simple reason is that we don't know when you, for example, take 2.5 milligram of the capsule of 2.5 milligram, how much quantity of the drug will be in your blood, and this may be more than what we planned. So some conditions which may lead to potential risk for the patient are for the moment excluded.
Cannot be over the age of 80. That's not a condition, but you can't be over the age of 80, that kind of thing.
Absolutely. And for example, the reason why is because after the age of even 75, the elimination of our metabolism changed quite a lot. The speed of elimination of certain compounds, including this drug, is expected to change, and therefore it will be significantly different from the population we are including, which is 18 to 75 years old.
Thank you so much. We have just a couple minutes here remaining. I'll ask a kind of a follow-up question to that, and this will be our final question for this evening's presentation. Does this study help with TN and chronic migraines? So I'd like to broaden that a little. Are there other conditions that this drug has been found to help with during the trial?
Well, I'll let Amin handle that.
Yeah, so there is another, today we did not explore if this drug could work in migraine. We don't know. We don't have today detailed understanding of the migraine physiopathology and if this drug could work or not. And we will see that. This drug is specifically developed in one condition, which is called tuberous sclerosis complex. And we hope that the drug will help patients with tuberous sclerosis complex. What is this condition? It's a genetic condition, which is characterized by mutation of two genes. This mutation leads to synthesis of oversynthesis of certain proteins in many organs, like the eyes, like the brain, and like the kidneys. And in patients, usually one of the most frequent symptoms is non-controllable and difficult to treat seizures. And the seizures are not responding to normal anti-seizures medications. And we believe that the mechanism of action of this compound, which is inhibiting the synthesis of certain proteins in the brain and blocking this over signaling of glutamate receptors, may help also this patient. So this is the indication we are pursuing today, and this is the beginning of the research in this compound, and we will be looking for indication where this drug will bring benefits to the patients.
Excellent. Thank you. Dr. Sakulla Amin, thank you for a fantastic presentation this evening. And thank you to everyone joining us for this evening. Please return to the agenda where you can choose from Dr. Brisman's patient Q&A on what you should know about TN and visiting the dentist, or select from one of our 4 support groups, all beginning at the top of the hour.
Brandy, I'm going to just add 20 seconds. Because
Please.
someone asked in the chat, and I just found these chats, and you all did an excellent job, but someone asked, can you be in the trial if you've had prior surgery? And the answer is yes, which is it's a really a well-run, well-developed study. But yes, you can be in the trial if you had surgery, it was successful while it's no longer successful. It does not eliminate you. And that's great, because there's no funny business about that, and it doesn't affect the company's ability to evaluate the responsiveness of this drug.
Excellent.
Or the efficacy of this drug, excuse me.
Fantastic. Thank you so much for adding that. Amin, did you have anything that you wanted to say on a final note there?
Thank you very much for your questions and for your attention, and looking forward to continue this conversation with all of you.
Okay, thanks everyone in the audience for joining us. Thank you, Brandy, and thank you, Amin, for joining us.
Absolutely. Thank you so much.
Bye.
Thank you.